Good afternoon and welcome back to Grand Rounds. Please remember to sign the attendance record and also please remember to fill out the program evaluation and please give us any ideas that you might have in regards to future topics or future speakers. Today I have the pleasure of actually reintroducing Dr. Jeritt Tucker. As you may recall, he attended his undergraduate education here at Iowa State, and then he stayed to get his Ph.D. in counseling psychology. He currently is assistant professor at Des Moines University, and also he is the clinical psychologist here at the Cancer Resource Center, and he kindly has accepted our invitation today to update us on how to engage with the difficult patient, and please join me in welcoming Dr. Tucker.
Thanks, Dr. Thanks, Dr. Halpern. Can everybody hear me okay? Okay, good. Well, apparently we've encountered some difficult patients. It's a good turnout today, so that's a good sign. So today we're really going to talk about what the process that we all have to engage in when we're encountering some difficulty. We're going to give some examples of what different patients might present with, but the general protocol that we can all use is pretty consistent between patient populations. But to motivate why this is a really important dialogue that we're having today, more than just like a sort of a venting session about difficulty, is that there's a real disparity in health outcomes when it comes to patients who are labeled as difficult, right? So we know that the discrepancy in life expectancy for patients with mental health concerns, borderline personality disorder, schizophrenia, some of the more severe mental illnesses, is about 13 to 30 years, right? So somebody with that diagnosis can expect to live about 13 to 30 years less than a person without a mental health diagnosis. And that discrepancy is, while very startling, is actually not so attributable to the effects of the mental health condition itself, but rather due to the higher rates of physical comorbidities in these patients, right? So things like hyperlipidemia, things like obesity, cardiovascular disease, diabetes mellitus, all of these have about 1.5 to 4.5 times higher prevalence rates in these patients. The reasons for this are many. We know that with any health disparity, there's also environmental factors that are going on. There's social economic factors that are going on. Folks with mental illnesses tend to live in more poverty. They tend to have more difficulty with self-management. But it also has a lot to do with the clinical care that we provide to these patients. When we ascribe the label difficult, what sort of happens interpersonally with a patient in that moment? When we've given that patient that label, that difficult label, that borderline label, or whatever it might be, we're much less likely to give them fewer assessments, even very, very simple things like blood pressure, managing or assessing their weight. We're more likely to delay their diagnosis of a physical health concern because of that fewer screening and assessments. They're also less likely to receive kind of the standard of care. We give fewer prescriptions of statins for those with high cholesterol. We give fewer surgical procedures. So the reason for this is when we give somebody a diagnosis or a label as difficult. You've probably heard it before. I've used some of these labels myself when I've encountered a very difficult patient. I step out of the room and I go, oh, man, that patient was such a jerk, right? Or whatever it might be. In that moment, I say to myself something that helps me to manage the difficulty. It gives me some relief to acknowledge or to say, that was really tough, right? But when we label the patient in that sort of shorthand, it sort of stands as a heuristic for that entire patient. We've sort of labeled them now as the angry demander, as the frequent flyer, as the borderline patient, as the treatment-resistant patient, et cetera. And when we do that, we're much more likely to ignore or think that any physical complaints that they might have are owing to their difficulty, to their illness, right? That patient's just being crazy. That patient's just being demanding, et cetera. And that is largely what's attributed to these discrepancies in quality of care that we provide to these patients. So in today's presentation, I'm going to try and foster some empathy for difficult patients. That we ourselves are often difficult with our loved ones. We have difficult moments, et cetera, so that we can kind of start to blur the line between patient and provider, so that we can come at this from a place of both emotional and cognitive understanding. And those two things are actually a little different, emotional and cognitive understanding. And I'm going to target both of them in the presentation today. But they're a little different in that we don't have to just feel what our patient feels. In fact, when we're in the room with a difficult patient, there's a lot of things that are going on that we're already experiencing what our patients are experiencing. There's a whole system of the brain, the mirror neuron systems that are distributed throughout different parts of the brain that are allowing us already to feel what our patients are feeling. So it's not really a problem of empathy, I'm going to suggest, but rather to sort of engage in the process of trying to understand, of label what's happening for me in this moment, what's going on in my brain and body, and what might be going on for my patient as well. So we're going to foster both kind of cognitive empathy through trying to kind of go through some of the neurobiology of difficult patients, but also some emotional empathy by experiencing some of these difficulties in vivo firsthand. Okay? So by the end of the day, my hope is that we might recognize some of the common sources of difficulty we experience with our patients so that we can move from maybe this broad level of this patient is being a jerk to, this patient might be experiencing some anger, and this is what the neurobiology of anger is like in the brain. Or this patient probably maybe has a psychotic disorder, something like that, right? And then through that to foster this sort of emotional and cognitive empathy. And then ultimately we can identify some steps that we can use for ourselves. I'm hopeful to leave at least 10 minutes at the end because I think what this really is going to come down to is us discussing with one another difficulty that we've been encountering with patients, right, to bring this home. So all of this being said, while I'm trying to help us to understand our patients, and the key point that I will make is that there's always a valid reason that your patient is being difficult, even though we might not want to believe it in that moment. There's always a good reason. That is never to say that there's a good reason for you to be mistreated as a provider, right? There's never a valid reason for you to be harassed, threatened, physically assaulted, or discriminated against by a patient. So much of the literature focuses on physicians or nurses or healthcare providers' discrimination against patients, but so much actually the commonality of being discriminated or harassed by a patient is actually pretty high. As many as about almost 60% of nurses will report having been harassed by a patient at some point, almost about 50% of physicians. And there's a real gender discrepancy there. Women are much more likely to experience, especially sexual harassment, right? So all of what I'm doing today is not to try and say that you deserve to be or you should tolerate being mistreated by a patient. Rather, it's sort of those moments when there's anger in the room or some difficult emotion and how to handle it. All right, so let's start with the angry patient. All right, so I'm really excited to announce that I spoke with the administration this morning, and actually they're going to administer a 300-item irritability scale to you all today. So this irritability scale is required of all MGMC employees, all right? It only takes about an hour and a half to 3 hours to complete, so don't worry about that, but it is due this evening by 12, okay? So I know you probably are planning to go home after this or whatever it might be, but I'm going to need you to complete the questionnaire. It's only about 350 items, okay? And also, if obviously you can't be reimbursed for your time, so I apologize about that. All right, so you're probably beginning to feel a little bit of your heart rate go up, maybe. You may be experiencing some approach-related cognitions. You're wanting to rush down, charge the podium, and tell me how unfair it is that I would ask you to do this, right? And that emotion, anger, despite our Midwestern roots, which tells us that it's not appropriate to feel anger, is very, very adaptive, very, very healthy, very, very important, right? It tells us or it alerts to us that there's some injustice that's being done, some object that's in the way of something we desire, we want, we need, and that object deserves to be removed. And in this situation, do you deserve to take a 350-item irritability scale just because I told you to do it? Probably not. If you suppress that anger, right, you'd go home, you'd be all frustrated, you'd fill out the questionnaire, every moment regretting it, just getting more and more hostile, having more angry ruminations, right? And eventually it might spill over. So the point of all of this is just to say that anger is common, it's important, it tends to be temporary, it's actually pretty safe. Actually, in close dyadic couples, angry expressions lead to improved relationships more often than not. Right? Anger is actually very important to highlighting needs and expressing them. 75% of Americans feel irritable multiple times a week. I'm one of those 75%. This week, just driving in traffic, even on the way here, I got angry, but I managed it. I didn't honk, although I really wanted to. Angry feelings tend to dissipate within 10 to 15 minutes. They don't last that long, but we can ruminate on them to increase those feelings of anger. And anger is generally safe, even in hospital environments. It's only followed by aggression about 10% of the times. Even the most irritable, angry patients only tend to move toward aggression about 10% of the time. While there's a lot of disorderly conduct that occurs, aggression is much less common in hospital settings. And there are things that we can do as providers to kind of help move away from the likelihood of that aggression. So as we talked about, anger is a negatively valence. Most people don't like the experience of anger. You know, on a scale of 1 to 5, most people rate it at a 1.5, being less than neutral. It's approach-related. It means it's moving us toward an object as opposed to avoiding an object. So basically, in other words, when your patient's angry, they're feeling that they have been treated unfairly, and in this moment, you are a stand-in, whether rightfully so or not, for that anger. You know, there is something called the proximity bias, meaning when we've had a lot of angering things happening in our day-to-day life and we've tended to suppress that, as maybe Midwesterns are likely to do, we tend to then find, it's called displacement, right, or proximity bias, things that are easy receptacles for our anger. So it's not always the case that we have done something wrong as the provider. And it's important really to remember that, I think, in that moment, to say, okay, the patient is really experiencing a lot of anger right now. I'm feeling to blame for this, right? You're the stand-in, or you are that blockage to some need the patient has identified. What's happening in the brain is basically the same thing. It's a lot like fear, anger in the brain, except it's processed by a different part of the prefrontal cortex, the left side, which is more approaching, whereas fear tends to be processed more on the right side of the prefrontal cortex, which is more avoidant. They've detected a threat, so the same rush of hormones related to threat detection and avoidance has happened. You know, you have the vasodilation of the large muscle groups preparing you to fight or flee. You have a narrowing of focus on me in this case, if I'm asking you to do an irritability questionnaire. You have some hypervigilance. And then you start engaging in some planning, right, through the left prefrontal cortex to try and organize how am I going to address this stressor. For patients who have chronic anger problems, as in the case of antisocial personality disorder or other conditions of that regard, they actually have a little bit reduced gray matter in that left prefrontal cortex, right? So it's harder for them to bring that planning online. It's harder for them to manage that fearful, angry response that you all engaged in that moment that you managed your irritability toward me. So what's really important with angry patients like this is not to avoid, right? Because you are the object. You're the stand-in for their anger in that moment. So if you tend to avoid, it's likely going to increase rumination, and unfortunately, it's likely to increase to litigation, to lawsuits, if a patient feels like their anger can't be heard. So instead, it's very important to acknowledge what you think might be happening, and we'll talk about the protocol for each of these at the end. And then to try and engage that, as much as you can, that planning into some collaborative problem solving about what to do together. All right. And again, as I was mentioning, you know, it's very tempting to want to avoid difficult patients, to want to avoid angry patients. But again, avoiding them is more likely to lead to litigation because they felt like that anger hasn't been able to be resolved, right? It hasn't had an object that helped to manage. So actually acknowledging problems in the encounter, acknowledging the anger, sort of counterintuitively, acknowledging there's a difficulty is more likely to reduce malpractice suits, along with lead to better outcomes. All right, let's talk about the needy patient. Has anyone felt like they've experienced a needy patient before? Felt like they were asking a lot of you, maybe to go above and beyond? Felt like they maybe couldn't control their difficulties? Well, let's do a real quick role play here. So underneath everybody's chair, I've put a piece of paper. Don't look at it yet. Underneath, I put a piece of paper, and on that paper is either a 0 or a 1. And if it's a 1, you're going to be asked to come on down and role play. I've got the script here. We'll have you role play a difficult patient encounter, okay? So on the count of 3, I'm going to have you reach underneath, and you're going to pull out the sheet of paper. Okay, 1, 2. I'm just kidding. There's no paper there. Don't worry about it. All right. So what did you feel in that moment as I was asking you to do that? If you're an actor, maybe you felt exhilarated. And actually, the difference between joy and fear is all about attribution. If you think that this is going to be a positive experience, those same feelings that make you worried are actually going to lead you to have a pleasurable release of dopamine. But for most folks, that's a scary moment to be asked to do that, right? And now, as I've told you, we're not going to do the role play. Slowly, your parasympathetic nervous system is taking over. You're taking a deep breath. And even glucocorticoids, which act at a genetic level, those things that are involved in stress, are actually beginning to have a negative feedback loop, even within a couple of minutes, to tell you that it's okay, right? That I can calm down. The stressor has passed. This moment, I'm okay. For patients who are needy. And needy is often a stand-in for trauma. Neediness is often a stand-in for trauma. So for the case of borderline personality disorder, almost 75% roughly have been identified to have childhood trauma, particularly sexual trauma is likely to lead to borderline type personality disorder. So those patients who we feel sometimes are manipulative, who are needy, who are very demanding of us, often it can be attributable to trauma. And what happens with trauma is in that moment when we were able to maybe regulate ourselves, we were able to calm ourselves in that moment, is that system of feedback is dysregulated. So it's very difficult for a patient with trauma, and there's diffuse effects and more research. We could spend probably another several weeks just talking about the impacts of trauma on the brain. But basically, it's much more difficult for a patient who's been traumatized to regulate stress response. Chronic stress leads to dysregulated stress response and altered circadian rhythms, right? So different cortisol tends to rise early in the mornings and fall throughout the day. For patients who've experienced chronic stress or trauma, that circadian cycle is dysregulated, leading to difficulties with sleep-wake cycles, difficulties with autobiographical memory. The volume of the hippocampus and the amygdala, which are responsible for encoding memory, tend to be reduced. Greater negative emotionality, and even changes in pain reception, right? So endogenous opioids tend to have a more difficult time in terms of regulating pain. There's a lower feedback. So all of this is to say, basically, the temptation to want to label the patient as needy is strong if we feel like a lot is being asked of us. The purpose of this is hopefully to give a little bit of understanding of what might be going on so that we can recognize that this might be what's happening for this patient. We can we should try to take them seriously that they are having a very hard time regulating, not because they're crazy or irrational, but literally their brain chemistry is different. We shouldn't ignore threats of self-harm and call them as manipulations because there tend to be much higher rates. Makes sense if you're chronically disrupted, if you're feeling like you're going to be called upon in front of an auditorium of people at all times of the day and unpredictably, of course you might feel dysregulated and feel uncomfortable a lot of the time. So instead, it's important to keep messages very simple, and especially when we're feeling like there's a lot of demands being placed on us, to get support from colleagues as well as mental health professionals or make referrals as needed. Speeding right along here. All right, so finally for the crazy patient. Actually, we have one more after this. So to give you a sense of the crazy patient, as I'm talking here, I just want you to imagine that the sounds that you're hearing are kind of just going on throughout the presentation, right? That as much as you are hearing the sounds that are kind of dysregulated, imagine that that's happening throughout the day, right? So imagine that what would happen if it were to continue, right? In this moment, you had a sense that I was doing a demonstration. But if you were to have difficulty with sort of the salience of different sounds throughout the day, that can lead to sometimes just needing to find a way to cope, right? So what we tend to do, and what folks who are experiencing psychosis tend to do, is come up with an explanation for why that's happening, right? If I were to continue to make that raspy noise, you might try to find an explanation for what was going on. Does he not know that's happening on the microphone? Should I tell somebody about this? Does anybody else hear this, right? Those sorts of experiences. And so delusions that seem very illogical to us, if we've not experienced psychosis, make a great deal of sense as a way of helping to manage that sort of constant stimulation, right? So psychosis has sometimes been called aberrant salience, is a big term that just basically means that it's hard to determine the salience of different stimuli. It's hard to know how loud or to interpret motivation. So for you, you're interpreting that this is a lecture that you're supposed to be attending, that you're trying to make sense of what I'm saying. You're not supposed to be speaking up. You're not really paying attention to the other sounds in this room. You're able to kind of put a spotlight on myself in this moment. But it's very difficult to do due to dopamine dysregulation that's happening. It makes it hard for somebody who's experiencing psychosis to do that same process of selecting which stimuli to attend to and how to do so. Okay? And then delusions are often an attempt to just make sense of that experience, right? They are actually if you talk to somebody with psychosis, the sense that a delusion can make internally, right? It has a very good internal coherency in terms of explaining what might be going on, even though it doesn't necessarily jive with reality, right? It's a way of making sense of this difficulty. So it's important, again, to not minimize or try and dispute someone's delusion or try and dispute someone's experience, but just to acknowledge that that's their experience. You can, of course, set healthy boundaries, say, I certainly can't relate, or I don't hear what you're hearing right now, but I understand that you do, and then that's very distressing, right? It's never useful to try and dispute that. All right, so let's end the final patient. I've given you a smattering of difficulty here, with perhaps the most difficult patient for many reasons, but also the most difficult patient to empathize with. And in many studies of stigma, addiction is oftentimes the most stigmatized patient population. And that's because addiction tends to start with a behavior, right? With addiction, there's some behavior that this patient has done initially that we, therefore, as the outside observer, sort of give a sense of controllability, that this patient has some control over their addiction. And therefore, we tend to see them as having lower willpower, right? We tend to give a moral judgment. You could stop the behavior. And the purpose of this section is really just to say, just like all the other patient populations we've been talking about, there's a very real neurobiological mechanism that's going on in addiction, right? Just as all the other patient populations. And maybe you're already aware of this, but I'll say it again here. So basically, with addiction, we know that illicit drug use is remaining pretty stable, and it's remained stable for the past several decades or so, but the misuse of prescription medications continues to rise. About 30% of prescription narcotics are now diverted for illegal use. So these patients, there is the reality of drug seeking, a very real reality. Unfortunately for us as the physicians, the clinic itself is becoming sort of a context clue for drug use, right? When anytime we have a pleasurable experience, we also we form memories about the environment around us in which we've had that experience. And with the case of drug-seeking behavior or the use of prescribed medications, the clinic, the hospital itself, sort of becomes a contextual clue or a cue for the release of the same chemicals that occur when we're engaged in using a substance. So basically, we unfortunately kind of represent a lot of drug-related stimuli as a hospital provider. With addiction, then the only way to build empathy for addiction maybe is to talk about the experience of love, if you've ever experienced love yourself. The same system, the ventral tegmental area and the nucleus accumbens that results in reward and pleasure and craving for the loved one is the same thing that's being affected by opioids, maybe about 1/1000th of the extent in the case of love versus opioids. So opioids are a very magnified experience of love. And actually the addiction literature reads a lot like a romance novel, if you've ever read through that. So this system, so initially that sort of experience of reward is occurring in the brain. And there's actually a lot of genetic components to that experience. We'll talk about here why. We won't get too nitty-gritty here, but basically tolerance or the need for more and more substance comes from the downregulation of receptors in the nucleus accumbens. So basically, in response to having elevated levels of opioids, now that area of the brain that's getting reward, or it's being rewarded, responsible for reward, begins to downregulate, meaning it's not as sensitive. So we need more and more of that substance. What's really interesting is that how much that cell downregulates has a lot to do with genetics. And that's why about 50% of addiction, even as high as 60 to 70% in alcoholism, is related to genetic heritability. Right? So we often think of addiction as a personal failing, but it has a very strong genetic component, just like all other diagnoses that we work with. And the tolerance and dependence is sort of the definition of addiction. And it's at this point that it's moved just from a pleasurable experience to a real neurobiological change. Dependence results from opioids' impacts on other areas of the brain, not just the reward circuitry, but also those systems that are responsible for very basic survival. Things like breathing, blood pressure, regulation of blood pressure, and wakefulness, right? So when we have developed tolerance, start taking more opioids, when we stop, we experience very negative sort of side effects. And just like with anger, where we need the frontal lobes to help regulate that craving, to help regulate those negative experiences, with folks who are experiencing addiction, the frontal lobes have actually begun to be disrupted. So there's sort of a really degradation of the feedback loop that's supposed to help this person sort of regulate that difficulty. So there's real difficulty with helping to control the impulse to seek out that craving. So all the neurobiology is maybe not as important as just the recognition of the reality of what's happening in the brain, right? That there's some real changes that are occurring. And then a large part of that happens to be genetic heritability. So let's put this all together, and then we'll jump into maybe just a dialogue about difficulty that you're experiencing with patients, about what do we do when we're experiencing this difficulty. So what I'm going to try and encourage us to do is sort of not necessarily jujitsu in terms of how do we respond to difficulty, but something similar to that. But it's based off of a real compassionate care for the person in front of us, a cognitive and emotional empathy for the person in front of us. Difficulty, when we ascribe that to a patient, is always the product of an equation, a very simple equation: patient times provider equals resistance. It's very much not an intrapsychic phenomenon. Even though I've been focusing so much on the patient themselves, the experience of difficulty in the room with the patient has much more to do with the interaction between the two. The more we try to kind of confront, argument, or persuade our patient, the much more likely we're going to experience difficulty, the much less likely we are to feel like we're having a positive encounter with our patient, the much more likely they are to resist. And think about it, right? If you're experiencing anger, if you're experiencing fear, if you're experiencing craving, all of these things, to invalidate any of those things only heightens the need, only heightens the rumination, only heightens sort of that experience. Whereas if we can really speak to the amygdala, if we can really speak to the limbic regions that are responsible for the emotion, we can really help to regulate the patient in front of us. It starts, though, first by regulating ourselves. So in order to regulate a person, in order to regulate somebody's emotional response, we have to be in a pretty good place ourselves. Again, sort of as I was mentioning earlier, empathy is not the problem. It's not a matter of you all having more empathy. I can tell you're all very empathic persons just looking at you. But I think we focus a lot on, I need to develop more empathy for my patient. I think we all care a lot about each individual patient in front of us. In fact, we care so much that we need to label the patient, or we need to ascribe them as being difficult in order to take a step back, right? Because we're beginning to feel dysregulated. We're beginning to feel overwhelmed. And using man, that patient was a real jerk, helps us to alleviate some of that feeling. We're already empathizing. So we need to, in that moment, recognize what we're feeling. So first of all, as always, make sure you're safe. This is not something to be used if your safety is on the line. Although, again, the majority of aggression can be handled without calling security. 80 to 90% of the time, it's not going to lead to direct physical acts. So make sure you're safe, first of all. And secondly, acknowledge that this is a difficult encounter in the moment. This is a really difficult encounter. We might try to avoid saying this is a really difficult patient, but just notice this interaction is very hard, right? This moment is very difficult. Give yourself that sort of compassion in that moment. Your gut will already have already found that difficulty, right? So we're just telling ourselves what our gut already knows. And then breathe. I know it's like said millions and millions and millions of times, but there's a real good reason why you breathe. Every time you exhale, you're stimulating the vagus nerve, which is telling your heart rate to slow down. You're literally regulating your own sympathetic nervous system, right, by exhaling. So taking a moment to just breathe, we can kind of move ourselves away from sympathetic control, fight or flight. This patient is a danger, I need to get out of this room, toward, okay, I'm safe, at least right now. And then that groundedness, that moment, is going to really help to down-regulate your patient, even if you don't say anything, right? By doing that, when we're under parasympathetic control, we have greater vocal prosody. There's more intonation in our voice. We're more likely to have sort of just spontaneous real encounters with people, as opposed to scripted, I gotta get out of the situation, uncomfortable, I don't know what to do situation. And we're also much more likely to mirror warm facial expressions. And there's something called emotional contagion that happens all the time. If I were to come in here and scream at you, you would probably feel afraid. You would start to feel those same emotions that I'm sort of portraying. We tend to just be very affected by the people around us. So if as a provider we can be in a grounded place by taking some breaths, we're really going to help to regulate the patient in front of us. So this is sort of the emotional empathy side. It's basically just unlocking your own empathy that already exists. The second is to engage the cognitive empathy, to seek understanding. And I think the key to this is really just assume there's a valid reason. You don't get it right now. I really don't get why this patient is being so difficult. It doesn't make sense to me. But you have to assume there's a valid reason. There almost 100% of the time is. It might not be, you might not agree with it. You might not feel like you're responsible for it, but there's usually a valid reason why a patient feels upset. So asking, can you help me understand what's going on? Can you help me understand what's going on for you right now? So in that moment, you're actually engaging their frontal lobes as well, right? You're helping them to regulate their own emotional response. You're getting that frontal lobe online. Make sure that you ask for clarification. What I hear you saying is X. Have I got that right? It's very tempting to assume we might know what's going on for the patient, but instead, really taking a moment to help with clarification. And once you've got it, or once you think you've got it, validate it, and just validate the heck out of it, right? That makes a lot of sense to me why you would be feeling that way. Of course you're feeling upset that your lunch has been delivered cold the past 3 meals. If I got my lunch cold, I would feel uncared for, or I would feel X, Y, and Z, right? It makes a lot of sense to me. Again, that doesn't mean that you agree with the patient's experience necessarily, or that you are even responsible necessarily, depending, but you're just validating the emotional expression itself. Usually if you do steps 1 and 2, you don't even have to go to 3. So 3 is to kind of address the patient's needs. But oftentimes what I found, if I do steps 1 and 2, if I've really engaged in cognitive and emotional empathy, there's no need actually for a lot more further problem solving. Oftentimes patients need to just understand that they're cared for, to need to have some regulation in that moment, to kick back into gear. And when they do, they begin to feel, oh, okay, I'm maybe reacting very strongly in this moment. So don't assume what your patient might be needing. If you're going to move to step 3, which is to try and kind of get some collaborative agreement on how to address the problem, ask what would help them in the moment. How would you like me to help? And if the request is pretty reasonable, just go for it. If it's something very simple, we can absolutely, we can make sure that we get your meals delivered within the first 5 minutes of making them, whatever it is. If it's reasonable. If it's unreasonable, though, just acknowledge your limits. I really wish I could do that for you, but our policy is really clear here. I can't do that. What else might help with this situation? Or here's what I can do for you. And just hold firm to those boundaries. And just repeat your position politely and calmly as necessary. Now, this is not going to work all the time. It's not a magic bullet necessarily. It's very helpful in these moments, but there are patients who, even despite your efforts, are not going to be helped in that moment. They're going to be continuing to express difficulty. There's some pretty extreme examples, right, especially in the news of drug-seeking patients who then, patients who are experiencing addiction, who then, end up harming their provider. So if you ever feel stalked, if you ever feel worried, if you ever feel that your safety is on the line, that is, obviously the time. You've tried steps 1, 2, and 3, and there's not any resolution. It's never appropriate to excuse that sort of behavior. It's never good to sacrifice our own well-being or pretend there isn't a problem. Instead, first just clarify that a boundary crossing has occurred. That it's really inappropriate that what has happened. Make that boundary clear to the patient. And if they don't respect that request, it's time to obviously seek support, right, from security or another service, and make sure that you're documenting everything that's happened. So again, the purpose of this presentation was help us to empathize a little bit more directly. But our duty is always to serve and accept all patients, but that doesn't mean we should have to accept abuse from those patients, right? So basically, in summary, Angry patients are experiencing blockages to goals they perceive that are unfair. Needy patients tend to be experiencing the sequela of trauma. Psychotic patients are experiencing the aberrant salience of stimuli, as you all experience. Drug-seeking patients are experiencing conditioned associations with biological dependence. So all of this is just to say there's usually a valid reason why your patient is being difficult. And if we can ground ourselves, we can engage in emotional empathy. If we can seek understanding, we can engage in cognitive empathy. And then if we can negotiate a collaborative agreement, we can help in regulating, avoiding difficulty down the line. All right. So we actually have quite a bit of time here toward the end for questions and a dialogue. So I'm curious, there's a lot of folks in the audience, so I'm wondering if it's being driven from difficult patient encounters. And obviously, we want to preserve all patient confidentiality. But if you're having questions about a particular patient example, what to do, or needing support, or you have questions about what I've talked about, absolutely feel free. Yeah.
I think we all know that there are some biological reasons for opioid dependence, but one issue that was recently in the news, and I wonder if you might comment about it, there was a nurse at one of the Des Moines hospitals who was stealing opioids out of the patient's own supplies, so the patients were suffering. And the hospital is now, a huge lawsuit by a number of those patients wanting multi-millions of dollars. So what's the individual nurse who stole the opioids? What's his responsibility and accountability? Right. Because I think he's saying, well, I was opioid dependent and it was a biological problem in my brain.
Yeah. So this is such a huge question about, and we could get into probably an interesting conversation about responsibility. And what I tend to, especially as a psychologist, is I always hold somebody responsible for their behavior, whereas I don't try to blame them for or judge them as an individual, right? So we can kind of judge the individual behaviors in that moment and say that this is wrong and obviously caused harm to folks without judging the individual. And then that has a lot to do with how we treat that individual, in terms of the court system as well, and what we want to do in terms of treatment. Do we want to see this as more of a rehabilitation? Do we want to seek justice? And all sorts of bigger issues like that. But I wish I knew how to wrestle with that question.
Hi. I think one of the things I see happening with difficult patients is they take time, or a difficult encounter is one that we often want to avoid, and so it seems more expedient to ignore the behavior or just get out of the situation, which doesn't end up resolving the problem.
Right.
But there are time constraints on everybody in healthcare, so how do we balance that out when it, for one thing, it's uncomfortable for us to deal with a difficult situation, so we sort of want to brush it aside. Right. And number two, it can seem like it can take more time.
Yeah, absolutely. And I'll argue maybe that this process that we engage in ultimately I think is time saving, because sort of as what I was mentioning before, when we tend to avoid the difficulty, it does tend to lead to expressions elsewhere. It tends to lead to more time, and just like when I avoid in my own personal life, which I'm likely to do with different projects and things, to manage the stress in that moment, it gives me immediate relief, but down the line it tends to lead to more problems. And the same tends to be true with difficult patients. So I would think that this process, and engaging with different patients myself, it's only maybe 5 to 10 minutes at most, versus the amount of time it takes to then help manage a phone call, an email, a difficulty down the line, disgruntlement later. This process tends to save us time ultimately. But that being said, my job as a psychologist is literally to engage in difficult patients, right? I work with a difficult patient, try and figure out what the assessment is, what's the diagnosis, what's the treatment going to be, and that's what I get paid to do. Whereas you are, not necessarily, your job has different descriptions, right? So if it is becoming that this is something you've tried to engage in, it's a good point for a referral to a mental health care provider.
That was the perfect segue to my question.
Good.
So I think most of the providers in my department do a really great job of following these rules, and
Yeah.
I feel like we're really effective in that way. One of the problems with it is that I feel like we are doing it a lot of the times because a referral to the more qualified person is either not covered by insurance or is going to take forever.
Yeah.
And so, can you please?
Yeah. Yeah, I'd love to fix it. Yeah. I feel like every time I give these presentations, we're like, hey, we should probably have more behavioral health care. And so maybe that's just the point of the presentation too, is to recognize that this is not something that you have the luxury of spending much time on, right? You've got a lot of other things going on. So I'm happy to join forces and help advocate. Yeah, absolutely.
So in my experience, the most difficult patients that I've had in my career are the borderline personality disorder patients. Do you have a quick and easy way to deal with them? They're particularly manipulative, and so I was wondering how you felt we could best, and you mentioned that 75% of them have a history of some abuse, and that's the case, but still, how do you deal with them?
Right. Yeah, it absolutely doesn't change, recognizing that trauma helps us to build empathy, but doesn't necessarily change the difficulty in management. And actually the best treatments for borderline personality disorder are something like dialectical behavior therapy. And dialectical behavior therapy involves typically a whole team of providers, right? Because it's very difficult because of what tends to happen with trauma. There's some different things that happen around splitting in terms of personality and managing all good, all bad feelings, that sort of thing. So the real treatments tend to be very comprehensive. And so especially with a patient where there's a personality disorder, you've sort of gotten that feeling after, you've probably tried the things that I've recommended, and it's not working. There's sometimes a lot of suicidal or non-injurious, self-injurious behaviors, that sort of thing. I definitely would recommend, referral to someone who can provide DBT or a similar treatment. Any other questions? I really appreciate you all being here. And if there are things that you want to kind of consult with afterward, I'm happy to do so. Great. Thank you so much for your time.